Skeletal muscle relaxants, as the name suggests, relax the muscle. That is, they decrease the muscle tone. And based on their site of action, skeletal muscle relaxants are classified as either peripherally acting, that is, drugs which act on either neuromuscular junction or directly on the muscle, and centrally acting, that is, the drugs which affect the spinal and supraspinal reflexes. So, in this video, we will talk about peripherally acting skeletal muscle relaxants. So, these drugs are further classified as told into the drugs that act on neuromuscular junction and the drugs which act directly on the skeletal muscle. Then, the drugs which act on neuromuscular junction are further classified into non-depolarizing, that is the competitive blockers, and the depolarizing blockers. Now, these NMJ blockers mainly are used for surgeries along with general anesthesia. Okay, and this has helped a lot because before general anesthesia, the depth which was required for the muscle relaxation was too much. Okay, so yes, the person will be unconscious and we need to relax the muscles as well so that the operation can be performed. Otherwise, if there will be an incision, there will be contraction of the muscle. So the dose of the general anesthesia required was much more. So now with the availability of the neuromuscular blockers, this dose of general anesthesia is much lesser, and because of the requirement of lesser dose, chances of respiratory depression are less and recovery is also faster. Then we will see that depolarizing blocker is used for small procedures like endotracheal intubation, bronchoscopy, etc. While these centrally acting drugs, they are used to decrease the muscle tone in diseases in which there is increased tone. So, certain diseases like chronic spastic conditions, acute muscle spasms, tetanus, in those diseases we use these centrally acting skeletal muscle relaxants. While peripherally acting drugs, we see that these neuromuscular blockers are used for the surgeries. Okay, so let us see what is the mechanism of action of these neuromuscular blockers. So, revising our basic physiology, how this neuromuscular transmission takes place. So here this is showing the presynaptic terminal. Basically this is a neuron and this is the nerve terminal which is showing forming the presynaptic membrane, and this is the postsynaptic membrane which is basically the muscle fiber membrane. Now action potential reaches the nerve terminal, and when that happens, the voltage gated calcium channels on the nerve terminals open. This leads to influx of calcium. So calcium moves from outside to inside the nerve terminal. This calcium causes a fusion of the vesicles. These vesicles contain the neurotransmitter acetylcholine. So these vesicles fuse with the membrane and there is release of acetylcholine in this synaptic cleft. Then acetylcholine binds to the N-acetylcholine receptors which are present on this postsynaptic membrane, and this postsynaptic membrane where this junction is taking place is also known as motor end plate. So on motor end plate, this acetylcholine binds to N-acetylcholine receptor which are nicotinic receptors and are of N-M type. Okay, nicotinic M type of receptors, and because of this binding there is generation of motor end plate potential. It reaches a threshold. This in turn causes of voltage gated sodium channels. So this N-acetylcholine receptors, basically these are same as ligand gated sodium channels. So when there is acetylcholine binding, these channels open, sodium enters causing motor end plate potential. This reaches threshold causing opening of voltage gated sodium channels. So here we have voltage gated sodium channels also which open. This leads to generation of action potential, and hence this action potential then travels along the membrane through the T tubules and there is muscle contraction. First there is basically excitation contraction coupling and this causes the muscle contraction. Now this action potential is causing the contraction, but you see that this acetylcholine which is released is destroyed almost immediately. So there is an enzyme acetylcholinesterase present in the synaptic cleft. This acetylcholinesterase breaks down acetylcholine to acetyl-CoA and choline, and these products are taken back into the nerve terminal and this acetylcholine is resynthesized. Okay, so very important that this acetylcholinesterase breaks down acetylcholine immediately so that this acetylcholine is not repeatedly binding to these and keeping the N-acetylcholine receptors stimulated like for a very long time, because we want that one action potential causes one contraction only and there should not be persistent stimulation. So this is the basic physiology. Coming to the mechanism of action, well, both the drugs of the neuromuscular blockers, that is the competitive neuromuscular blockers or non-depolarizing neuromuscular blocker and depolarizing neuromuscular blockers, both bind to N-acetylcholine receptors which are present on the motor end plate. Now, competitive neuromuscular blockers, they have the affinity for these receptors, but they do not have intrinsic activity. That means they can bind to the receptors. They will bind to these receptors, but they are not able to stimulate these receptors. So, basically, they will prevent the binding of acetylcholine. That's all. So, acetylcholine will not be able to act. There will not be any motor end plate potential, and hence no action potential, no contraction, right? Then we have the depolarizing blockers. They have the affinity, so they bind to these N-acetylcholine receptors, but they have some intrinsic activity as well, that is the submaximal intrinsic activity. That means, like acetylcholine, they are going to stimulate this N-acetylcholine receptors as well. Understanding? So that should cause contraction. Yes, that happens. So initially, when they bind, there is generation of motor end plate potential, there is action potential, and with excitation contraction coupling, there will be muscle contraction. However, unlike acetylcholine, these depolarizing neuromuscular blockers, they are not destroyed by acetylcholinesterase. Okay. So if they are not destroyed, they will remain here only in the synaptic cleft and they will keep stimulating this N-acetylcholine receptors. Now this is harmful. So initially, yes, there will be muscle contraction, but because of persistent depolarization, there is sodium channel inactivation. Yes. So what we say, there is action potential. See, what happens that when there is change in the voltage, sodium channels are in closed state at RMP, resting membrane potential, and when the voltage change reaches to the threshold, these sodium channels open. But very fast they inactivate. And they can go back to the closed state only when the muscle potential comes back to repolarization. Understanding? And they open only from closed to open state. Very important. That means sodium channels to open again to cause another action potential, they should go back to the closed state. But here that is not happening because there is persistent depolarization and sodium channels are stuck in this inactivated state because the muscle membrane is not repolarizing. So sodium channels inactivate, no new action potential since sodium channels cannot open, and that is why muscles relax. So with depolarizing neuromuscular blockers, we get initially muscle contraction, that is known as fasciculations. These are involuntary contraction, fasciculations, and then the muscles are relaxing. And the paralysis which occurs in both types, it is flaccid paralysis. Why flaccid paralysis? See, in upper motor neuron and lower motor neuron, we have read about spastic and flaccid paralysis. So, a lower motor neuron is basically from alpha motor neuron in the spinal cord to neuromuscular junction and then to the muscle. Anywhere, if the injury is here, then it will lead to flaccid paralysis. So here neuromuscular junction is affected in both the cases. So we get flaccid paralysis. Flaccid means there will be decrease in the tone of the muscle, right? So when we talk about muscle weakness, we are thinking about the power, that is the active contraction of the muscle. But when we are saying flaccid and spastic, we are thinking about the tone of the muscle. So flaccid paralysis is the weakness of the muscle and flaccid is decrease in the tone of the muscles, right? Now what are the features which we see in competitive neuromuscular blockers paralysis and the depolarizing neuromuscular blocker paralysis? So I told you competitive means they just bind to the N-acetylcholine receptor, there is no stimulation. Depolarizing neuromuscular blocker, they bind, they stimulate as well. So in competitive neuromuscular blocker, we see only flaccid paralysis, while depolarizing neuromuscular blocker, we see initially fasciculations and then there is flaccid paralysis. Now, there are certain features. Actually, with tetanic stimulation in the competitive neuromuscular blocker, we see poorly stained contraction. Let us see with the help of a diagram. So, what happens that here you have applied the blocker, competitive blocker, and this each line is telling about the contraction. Okay, so say suppose this is the maximum contraction we are seeing, and as we give the blocker and we stimulate the nerve, what we see is that the strength of contraction is decreasing. Now we give a tetanic stimuli. Tetanic stimuli means repeated very fast we are stimulating the neuron. Okay, we stimulate the neuron very fast and this neuron is supplying the muscle. Now initially there will be increased contraction. So here it has occurred, but initially we see that there is increase in strength of contraction, but that repeated stimuli is maintained and we see that the strength of contraction is decreasing. Why is this happening? So you see that, say suppose this is the presynaptic terminal and this is the motor end plate, right? So what we are doing is we are stimulating here. Now the your neuromuscular blocker is sitting on these N-acetylcholine receptors and it has blocked these receptors. Now when you stimulate this nerve very fast, there is increased release of acetylcholine. More acetylcholine is released. So that is why initially we get that increased strength of contraction. But when we repeatedly stimulate, the amount of acetylcholine continuously decreases. The amount of acetylcholine which is released decreases. That is happening normally also, but because the receptors are active, even that small acetylcholine is sufficient to stimulate the receptors. But in this case, the receptors are blocked. So this acetylcholine is not able to stimulate the receptor and we get a decrease in response. Okay, so the strength of contraction keeps on decreasing. There is another mechanism as well, that on this presynaptic membrane also we have these N-acetylcholine receptors, and this acetylcholine actually stimulates and there is increased release of acetylcholine because of this stimulation, this receptor stimulation. Now our competitive blockers block this receptor as well. So obviously there is decrease in the release of acetylcholine and this causes decrease in the strength of the contraction. Okay, so this contraction strength is decreasing. I can very well draw it like this, that with tetanic stimulation the strength of contraction is decreasing. Actually here if we see, we can draw it like this, that with each stimulation strength of contraction is decreasing. So this is known as fade phenomena. That means with tetanic stimuli strength of contraction decreases. Now as soon as the tetanic stimulation is stopped and we again stimulate the nerve, we get increase in the strength of contraction. So this is known as post-tetanic potentiation. So here you see the strength of contraction has decreased this much, but when we stimulate after the tetanic stimulation is over, again we get a increased strength of contraction. This is known as post-tetanic potentiation. So why is this happening? This is because in our tetanic stimulation, lot of calcium has stimulated in the presynaptic terminal. So yes, acetylcholine keeps on decreasing when we were stimulating it repeatedly. But now some time has passed and this acetylcholine has gone back into the nerve terminal, and this calcium which is still there will cause this acetylcholine to release again. So for one moment there is increase in the release of the acetylcholine and this leads to increase in the strength of contraction. So that is post-tetanic potentiation. But that doesn't happen with the depolarizing blocker. But one thing, we are discussing this, remember this is all the characteristics of partial block. If the block is complete, it is intense, then when we are giving the stimulation, then there will be no response from the muscle because the blocker has completely blocked all the acetylcholine receptors and then there will be no response. Here we are talking that when we give the drug, and then that time if we stimulate, then what is going to happen? Over time there will be complete and intense block. Understanding? So now we will see what happens with depolarizing blocker. So yes, initially what we see that this is the contraction, normal contraction, and if we give the depolarizing blocker here, initially the strength of contraction has increased due to the fasciculations that it is depolarizing the motor end plate, we have seen, and then the contraction is decreasing. Now if we give the tetanic stimuli, we see this is a well sustained contraction. Okay. So again it is in partial block, remember, well sustained contraction. So why we are seeing that? See, when we give depolarizing blocker, again tetanic stimuli, what is going to happen? It is going to release lot of acetylcholine, and this acetylcholine, again the receptors whatever are there, these are being stimulated by our depolarizing blockers. They are not like just sitting there, they are stimulating. So this acetylcholine is also sitting there. Okay, and there is depolarization. That's all. There is no fade, no decrease, because even with tetanic stimuli, if there is decrease in the acetylcholine, doesn't matter, because acetylcholine is not having any effect. Only the depolarizing blocker is having the effect of depolarization. This acetylcholine releases more, less, doesn't matter. Okay, so that's why we get a sustained contraction, but it is less in magnitude compared to the original contraction because the block has occurred, isn't it? So that is sustained contraction. Then there is also no post-tetanic potentiation. That means when we are stimulating after the tetanus, we don't see that increased response. Why? Because again, in post-tetanic potentiation, what we talked, that is because of calcium accumulation and increased acetylcholine release. But here, acetylcholine release doesn't matter, right? Because already depolarization is there, so it doesn't matter. So no post-tetanic potentiation. So those are the features which we see in case of tetanic stimulation during partial block and post-tetanic potentiation. In case of competitive neuromuscular blockers, there is a contraction but poorly sustained contraction, and we see a post-tetanic potentiation. In case of depolarizing neuromuscular blocker, well-sustained contraction, amplitude is lesser. Amplitude is lesser and it is during partial block, while post-tetanic potentiation is absent. Now, why we are talking about this? How is it helpful for us? Well, this tetanic stimulation during partial block is used to assess the effectiveness of the block. Okay, so there is a protocol known as train of 4 protocol. So in this 4 stimuli are given repeatedly and we see how is the response. So like in this competitive blocker, 4 stimuli when we give, what will happen? There will be one response and then there will be decrease in the response. Okay, now say suppose the original response when we don't give the blocker is this. This is the original response without the blocker. Now after the blocker we get this response. Okay, after the blocker we get this response. So obviously this is due to the block of the N-acetylcholine receptor on the postsynaptic membrane. But with tetanic stimulation we get continuously decrease in the response, and this effect is due to decrease in the acetylcholine release. Understanding? So that is how we understand this post-tetanic stimulation, and this is used to assess the effectiveness of the block. More the decrease in the strength of this fourth contraction, that means more the block, right? So as the block deepens, what we get is like this strength of contraction continuously decreases, and we take this ratio actually, strength of this contraction divided by the strength of the first contraction. So that will help in assessing the degree of the block. So that is the fade phenomena with tetanic stimuli to assess the degree of the block. Then what will be the effect if anticholinesterase is given? Anticholinesterase is a drug which will block the cholinesterase enzyme, and if cholinesterase enzyme is blocked, there will be increase in acetylcholine in the synaptic cleft. So this acetylcholine will block the reversal seen in the competitive neuromuscular blocker. Competitive means the drug will compete with the acetylcholine for binding with the N-acetylcholine receptor. Okay, so one side we have the drug, other side we have the acetylcholine, and both are competing for binding with this N-acetylcholine receptor. If the concentration of acetylcholine increases, then it will also bind more with these receptors and there will be block reversal. That is what we see with competitive neuromuscular blockers. With depolarizing neuromuscular blockers, actually there is increase in the block. Why is so? See, competitive, already we have seen that okay, increased acetylcholine will bind and it is going to stimulate the muscle, because in acetylcholine receptors there will be generation of MEPP and action potential. But with depolarizing neuromuscular blocker, already the muscle membrane is held in depolarized state and sodium channels are inactivated. Sodium channels are inactivated. So now if you add anticholinesterase, that is you are increasing acetylcholine, then there will be more depolarized state. It will more stimulate this N-acetylcholine receptor, more depolarized state, more sodium channels will be in an activated state. So that is going to increase the block or augment the block. Right? So that are the features of competitive neuromuscular blocker and depolarizing neuromuscular blocker, which we see at the muscle membrane. Then another thing is that what is the effect of cathodal current to end plate? Cathodal current is basically, just remember, adding negative charge on the outside of the membrane, and when we add negative charge on the outside of the membrane, muscle gets depolarized, and if it is getting depolarized, that means in competitive neuromuscular blockers it is going to decrease the block. Here we have seen that acetylcholine is depolarizing and reversing the block. So similarly here, depolarization will reverse the block and it enhances the block in case of depolarizing neuromuscular blockers. So moving on to another concept of phases of block in case of depolarizing blockers. Now, depolarizing blocker, I hope you have understood the mechanism, that is due to persistent depolarization. But in case that if the dose of depolarizing neuromuscular blocker, actually only known neuromuscular blocker in this case is succinylcholine. If the dose is more, or if it is not destroyed, see, succinylcholine is not destroyed by the synaptic cleft cholinesterase enzyme, but there is another enzyme, plasma cholinesterase, also known as butyryl cholinesterase. Okay, so it is destroyed by that enzyme. So suppose if dose is more or there is deficiency of this butyryl cholinesterase, in that case there can be phase 2 block. Okay, so initially there is block due to persistent depolarization, but if succinylcholine is maintained for longer duration, it will cause receptor desensitization because of continued stimulation, and this mimics the competitive block because now there will be no stimulation. Okay, so phase 1 block due to persistent depolarization, phase 2 block because of no depolarization, just like competitive blocker. So phase 1 block, in this anticholinesterases increase the block that we have seen. Phase 2 block, on the other hand, is partially reversed by anticholinesterases. So what is the importance of knowing this? Importance is that we should be aware of this, that if dose used is more or there is deficiency of plasma butyryl cholinesterase in a patient, then the patient can go into phase 2 block. And in phase 2 block, because it is a deeper block, we need to sometimes keep the patient on ventilator for approximately 30 minutes till the recovery has occurred, right? So that is the phases of block. So moving on to the actions of these blockers. On a skeletal muscle, we have seen what is the action. Just there is a certain sequence of skeletal muscle relaxation which occurs. So with competitive blockers, it is the fast small muscles which relax first. That is the muscles of the fingers and extraocular muscles relax first, then feet and hands and arm, leg, neck, then trunk and abdominal muscles, then intercostal muscles, and finally diaphragm is relaxed. So that time there is apnea, the respiration is going to stop. So obviously the person has to be intubated for the respiration, right? And the recovery occurs in the opposite direction. So first will be the diaphragm to recover. Okay. Second thing is that this respiratory paralysis and prolonged apnea is the most important complication of neuromuscular blockers, right? Then depolarizing blockers, yes, the sequence of muscle relaxation is different compared to that of the competitive blockers, but we will not talk about them because with depolarizing blocker, that is a succinylcholine, the action is so fast, it peaks so fast and it goes away so fast that there is no point of talking about this relaxation, because it is very difficult to note also that which muscles are relaxing first and last, right? Second is the action on the nicotinic N type of receptors. See, we have seen that the mechanism of action is due to the action of the nicotinic M type of receptors, that is the N-acetylcholine receptors. But this is like if the action is very selective, then only they will act only on those receptors, but that doesn't happen. There is some action on nicotinic N type of receptors and there is some action on muscarinic receptors as well. So these nicotinic N type of receptors, they are present on ganglion and adrenal medulla, and if these receptors are blocked, then it will cause ganglion block. There will be blockage of the sympathetic system, and if sympathetic system is blocked, there is decrease in the heart rate and decrease in the blood pressure. On the other hand, the depolarizing blockers, they will cause the ganglion stimulation, and this will lead to increase in heart rate and increase in blood pressure. Then due to the action on the muscarinic receptors, so muscarinic receptors basically are present on the target organ. For any autonomic nervous system neurons, we have preganglionic neuron, then the postganglionic neuron, and postganglionic neuron, in case of vagus, it releases acetylcholine, and this acetylcholine binds on the muscarinic receptors which are present on the target organ. So if this muscarinic receptors are blocked, for the cardiovascular system, there will be increase in the heart rate. See, parasympathetic system, what it does, it decreases the heart rate. Now we are telling that these muscarinic receptors are blocked, so that will lead to increase in heart rate. On the other hand, the depolarizing blockers, they are going to stimulate the receptors. So depolarizing blockers, their mechanism of action is by stimulation, so they are going to stimulate ganglion also, they are going to stimulate the vagus also, and this is going to cause decrease in the heart rate. Then one very important action is release of the histamine. Yes, histamine is by the direct action of these blockers, and the competitive as well as the depolarizing blockers may cause the release of the histamine, and this leads to flushing, hypotension and bronchospasm. That is the actions of the histamine. Now, one thing you remember, that the effect on the cardiovascular system will depend on the relative actions on these. Suppose there is more histamine release, but hardly there is ganglion block and hardly there is parasympathetic block by competitive blockers, then we will have histamine actions more. There will be hypotension, flushing. If ganglion block is there but parasympathetic block is not there, then there will be decrease in heart rate. So it is by the combination of the actions on ganglion, parasympathetic system and with histamine release, there is action on the cardiovascular system, right? Now coming to individual drugs. So first we will talk about the depolarizing neuromuscular blocker, that is succinylcholine. So succinylcholine, as said earlier, that it will stimulate the ganglion, it will cause vagal stimulation and it will also cause the histamine release. Now this succinylcholine, it is not metabolized by the synaptic cleft cholinesterase. In fact, it is metabolized by plasma cholinesterase. There is butyryl cholinesterase which metabolizes this succinylcholine, and activity of this enzyme can be assessed by Debuscane number. Now, the succinylcholine is very fast acting. The onset is within 1 minute, peak occurs in 2 minutes, and within 5 minutes recovery also happens. And because of this small duration of action, succinylcholine is used for small procedures like tracheal intubation, various scopies like esophagoscopy, bronchoscopy. So for all these procedures, small procedures, this succinylcholine is used. What are the side effects? Side effects is that succinylcholine increases all pressures. That means it increases intraocular pressure. So that is why it is contraindicated in glaucoma. Increases blood pressure by ganglion stimulation. Increases the intracranial pressure. So it is contraindicated in head injury. It increases gastric pressure also. So in peptic ulcer patients with GRD, that will be increased. Second thing is, because it is causing fasciculations and then there is flaccid paralysis. So fasciculations is, there will be like a fast contraction of the muscle. So this can cause muscle soreness and fatigue after recovery because of these fasciculations. Then there is risk of hyperkalemia, and this can land up in cardiac arrhythmias. Okay, hyperkalemia, always there is risk of cardiac arrhythmias, and then there is risk of malignant hyperthermia if this succinylcholine is given along with the fluorinated general anesthetics. Okay, so when we combine succinylcholine with fluorinated general anesthetics, there are chances of malignant hyperthermia in susceptible individuals. So that is about succinylcholine. Remember that succinylcholine is also known as suxamethonium, and it is the only known depolarizing neuromuscular blocker. And even though it is short acting, we have seen before that if there is pseudocholinesterase deficiency, that is the butyryl cholinesterase deficiency, then it can have prolonged action and then it can go into phase 2 block, and we have to be ready for the ventilatory support as well, right? Moving on to the competitive blockers. So in competitive blockers, depending on the duration of action, we have long acting drugs, short acting drugs and intermediate acting drugs. So in long acting, we have the prototype drug, that is G-tubocurarine. Okay, so this is the prototype drug, and that is why these competitive blockers are also known as curare type drugs. Okay. Now this D-tubocurarine is high toxicity. It causes much more histamine release, causes ganglion block, it causes vagal block. So it is hardly used now. But other long-acting drugs include PDP, that is pancuronium, doxycurium and pipecuronium. Among these, doxycurium is the longest acting and most potent. Now all these drugs release histamine, but pancuronium is the only drug which causes ganglion blockade and vagal block, but the doxycurium and pipecuronium are more selective. That is, they don't act on NN receptors and muscarinic receptors, so they are not causing ganglion block and vagal block, right? Now, because these drugs are long acting, obviously when they will be used for long duration surgeries, right? And generally these drugs require reversal. And how the reversal of the neuromuscular blocking effect will take place? We have to give anticholinestrases, that we have seen that anticholinesterase block the cholinesterase enzyme, increase acetylcholine, and that causes the reversal, right? Then we have the short acting competitive blockers. In short acting, we have mivacurium and gantacurium. Gantacurium is the shortest acting, acts for only 5 to 10 minutes. Mivacurium acts for 15 to 20 minutes, and this drug is metabolized by plasma cholinesterase, that is butyrylcholinesterase or also known as pseudocholinesterase, just like succinylcholine, and that is the reason that it is so much short acting. Again, they are very selective. They do not cause ganglion block and vagal block, and histamine release is also mild. Okay. So this mivacurium, because it is short acting, it can be used as an alternative to succinylcholine. Next is intermediate acting drugs. In intermediate acting, we have 4 drugs: vecuronium, atracurium, cisatracurium and rocuronium. Among these, vecuronium is commonly used in routine surgery and ICUs. In fact, it is one of the most commonly used competitive neuromuscular blocker. It doesn't cause any ganglion blockade, it doesn't cause any vagal blockade, and histamine release is also mild. Okay, very mild histamine release is there. So that is why cardiovascular stability is maintained in the patient, and that causes it to become the one of the most commonly used competitive neuromuscular blocker. Then we have atracurium and cisatracurium. The advantage of these drugs is that they undergo Hoffman elimination. Hoffman elimination basically is spontaneous non-enzymatic degradation. Okay, so they do not require kidney and liver for elimination. Hence, these are the preferred drugs for kidney patients and liver disease patients. And in fact, among these 2 drugs, cisatracurium is the one which is much more preferred, because atracurium, it causes some histamine release. Also, some amount of degradation is by cholinesterase enzyme, and this leads to accumulation of a toxic compound which causes CNS toxicity. Okay, so if it is used for long duration, it can lead to accumulation of that toxic compound which can cause CNS toxicity. Cisatracurium, no histamine release, no toxic metabolites, so preferred for liver disease patient, kidney disease patient, and also in elderly. Liver disease, kidney disease, why it is preferred? Because it undergoes Hoffman elimination. Then the next drug is rocuronium. Rocuronium has most rapid onset, MCQ, okay, most rapid onset, and that is why it can be used as an alternative to succinylcholine, mildly vagolytic, so that's why it can cause tachycardia. Okay, so it is blocking the vagus, so tachycardia. And rocuronium, one more thing you can remember, that this drug causes pain on injection. Yeah, that is an MCQ again. So rocuronium, 3 things to remember: most rapid onset, can be used as an alternative to succinylcholine because it doesn't have disadvantages of succinylcholine, that is, there is no depolarizing block, hardly any cardiovascular changes as well, and there is pain on injection with rocuronium. Fine. So what are the uses of the neuromuscular blockers? So neuromuscular blockers can be used as adjuvants to general anesthetics that I have discussed in the beginning of the video, because this will cause less dose of general anesthesia which is being required. Recovery will be faster, less chances of respiratory depression. The common ones which are used are pancuronium, rocuronium and cisatracurium. For brief procedures like endotracheal intubation, laryngoscopy, laryngoscopy, esophagoscopy, then orthopedic procedures like reduction of the fractures. For this, succinyl choline can be used because it is very fast onset and remains for only 5 minutes. Alternatives to this include mevacurium and rocuronium. Then they can also be used for assisted ventilation in case of ICU setting. So in ICU setting, when the patient is on ventilator, actually the movement of the chest kind of opposes the movement of the air which is being caused by ventilation. Okay, so that can be prevented by relaxing the intercostal muscles, and this can be done by continuous IV infusion of these drugs. By the way, all neuromuscular blockers are given by IV only. Okay, and in case of assisted ventilation, we are giving continuous IV infusion, right? Then they can be given during electroconvulsive therapy. During electroconvulsive therapy, there is a stimulation of the neurons. This causes convulsions, and this can also lead to trauma. So if the muscles are relaxed, it avoids the trauma, and this can be done by giving succinyl choline. Then these drugs can be used in severe cases of tetanus and status epilepticus, though we have seen that in tetanus we have the centrally acting muscle relaxants, not the peripherally acting skeletal muscle relaxants. But suppose if the patient is not responding, then in severe cases these drugs can also be used. Okay, moving on to the toxicity of these neuromuscular blockers, both depolarizing and competitive neuromuscular blockers. Actually, we have already dealt with this. Neuromuscular blockers, because they relax the respiratory muscles, they can lead to respiratory paralysis and apnea. Because of their action on the ganglion and also because of the histamine release, they can cause decrease in blood pressure and cardiovascular collapse. Then because of histamine release, there can be bronchospasm. Then hyperkalemia can occur due to succinyl choline. Malignant hypothermia again due to succinyl choline, and muscle soreness and myalgia. I told you that because of the fasciculations which occur, it occurs when succinyl choline is given, right? So these we have already discussed in the entire course of the video. Now, in case of toxicity or the prolonged action of the neuromuscular blockers, we need to reverse the action of the neuromuscular blockers. And we have seen in the long duration neuromuscular blockers that anticholinesterase is used for the reversal. Another drug which is used is Sugama-dex. This Sugama-dex is a chelator. Basically, it is a selective, it is also known as selective relaxant binding agent. Selective relaxant binding agent. So it is a relaxant binding agent. That means it will bind to the skeletal muscle relaxant, and it is specifically is used for rocuronium and vecuronium. And I already told you that these are the one of the most commonly used competitive neuromuscular blockers, right? So that was about the depolarizing and non-depolarizing, also known as competitive neuromuscular blockers. Moving on to the last part, one is the botulinum toxin. So this botulinum toxin actually acts by another mechanism. It prevents the fusion of the acetylcholine vesicles to the presynaptic membrane. Thus, it prevents the release of acetylcholine, decreases the release of the acetylcholine. Because actually here there are some T snare and V snare proteins. It interferes with that and prevents the fusion of the vesicles. So this botulinum toxin, there are various uses. Actually, it is injected into muscles of orbit for two conditions. One is ocular blepharospasm and for strabismus. Actually, in these conditions, there is excessive contraction of the extraocular muscles, and when injected into muscles, it causes their relaxation. Okay, so ocular blepharospasm and strabismus. Then we have facial wrinkles. You know about the Botox, right? So it is injected into the facial muscles to cause the relaxation of the facial muscles, and obviously, it is not like permanent. You have to repeat the injection in some time, maybe 3 to 6 months. Then there is achalasia cardia. In achalasia cardia, in the esophagus, lower part of the esophagus, in achalasia cardia, actually lower esophageal sphincter fails to relax. Okay, so this botulinum toxin is injected into the lower esophageal sphincter so that it relaxes and the food can pass from esophagus into the stomach. Okay, so that was botulinum toxin. Now, when we talked about the classification, I told you that in the peripherally acting drugs, we have the drugs which act on the neuromuscular junction. So, we have talked all about the drugs which act on neuromuscular junction. But I also talked that there is a drug which acts directly on the muscle, and that drug is dantrolene. So, once the action potential in the muscle membrane is generated, it travels along the T tubules. This is the T tubules. Okay, and there is a presence of a receptor here, DHPR receptor on the T tubules, and this is L tubule, that is the sarcoplasmic reticulum. It interacts with the T tubules, and on this L tubule there is another receptor, ryanodine receptor. Now, when the action potential reaches here, due to the interaction between DHPR and RYR receptor, there is release of calcium from this sarcoplasmic reticulum, and this leads to muscle contraction. Now, this dantrolene actually blocks this RYR1 receptor, right? RYR1, because this one type of receptor, it is present in skeletal muscle. In the cardiac muscle and smooth muscle, different isoforms of the receptor are present. So, it is acting only on the skeletal muscle. Now, once this RYR1 receptor is blocked, there is no calcium release from RYR, and hence there will be no contraction. So, muscle is going to relax. So, this dantrolene when given IV, so all the peripherally acting drugs are given IV. Dantrolene when given IV, it is the drug of choice for malignant hyperthermia. I told you, when can malignant hyperthermia occur? It can occur in predisposed individuals in which succinylcholine is given along with fluorinated anesthetics. Okay, so dantrolene is the drug of choice for that. It is also used in neuroleptic malignant syndrome. I am not going to go into details of that. Side effects of dantrolene include muscle weakness, then there is diarrhea, and liver toxicity can also occur. So, when this is given, it is important to monitor for liver function test, right? So, those were the peripherally acting skeletal muscle relaxants. And like all pharma videos, the video notes of this lecture will be available for free download from the app. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.